need in the future. It should avoid bad scars and poor shape. I did regular reductions for 10 years, and in 1995, I started doing liposuction breast reductions. My theory was I would reduce the volume with liposuction, and then 3 months later, do a mastopexy. Almost no one chose a mastopexy. I believe we were largely over-treating and wanting our ideal nipple position, and that's not what patients want. Why liposuction? I noticed that doing reductions, breasts were primarily fat. And there's a paper showing this. What I also found when I started doing this is there were a lot of patients who did not want the scars of a conventional reduction. That surprised me. I didn't realize it would be so high. This is a simple technique that anyone in the audience can adopt immediately, as long as you're doing liposuction right now. One should obtain a mammogram like for any patient, and in this case, it can be helpful to determine how much of the breast is fat. Next step is infiltration. We all do this all the time. This is the solution I use. You can use whatever your favorite is. And what I do is fully distend the breast. Usually it takes about 2 liters. I had one patient who I removed over 8 pounds with, and that's the one who had 4.5 liters per breast. Pre-infiltration, post-infiltration, I want it really firm. Suctioning, we all know how to do liposuction. I use 3 and 4 millimeter straight and angled cannulas. This is a simple procedure. It takes about 15 to 20 minutes per side, not hours. I use 2 stab incisions along the inframammary fold. I do the entire breast and the skin. And I think it's important to do the skin to get the skin tightening. This one you can even see the holes through the cannula through the skin. I have never had any skin necrosis despite making it so thin. This is what I think happens from the procedure. I do not remove 100% of the fat, but I get enough out to take the weight off of the skin, and the suctioning of the skin, I think, contributes to the tightening. That patient earlier after suctioning looks like this. It will go down a lot because, as you can see, we only got out about half of the fluid that we put in. And a lot of that will drain out for the next 4 hours. I do not use drains. Post-operative care, it's the same as I do for liposuction right now. I allow normal activity immediately, but no strenuous activity for 1 week. Patients are able to return to work at 1 week. I begin self-massage at a week, and that usually goes on for several months. I put them in a surgical garment, which they can take off for showering and bathing. I'm going to run through several of my early patients, and I think what you should notice is the skin retraction and how all of these patients were happy where their nipples were, and none of these requested to have mastopexy. Simple procedure makes this possible for patients who have unusual family dynamics. It's a good procedure for all ages, young and old alike. Breastfeeding is important to women. I've had 3 of my patients who subsequently referred their daughters for the same procedure. I've been in practice a long time in order for that to happen. In 2001, I decided it would be safe to do mastopexies at the same time rather than delaying them. It's a simple procedure. After infiltration, deepithelialization is easy to perform in just a couple of minutes without an assistant with the breast distended. You need to make a full thickness cut inferior to the nipple to allow for the transposition. An important thing that I do is no undermining. Your maximum tension is at the time of closure, and it diminishes every day after that. And I think as a result, I get much better scars than you do with conventional reductions. To date, I have not had to do a scar revision. Sometimes they need conventional, Weiss pattern excisions, and it's just as easy, but it takes a little bit longer. This patient had 7 pounds of tissue removed. About 8 years ago, I started offering this procedure to patients who had implants in place, whether it was keeping the implants or removing them. Keeping the implants, I found, was a less expensive approach than to changing the implants, and I thought with a lower complication. I've had hematomas, seromas, and infections with changing implants over the years, and this avoids that problem. I'm often doing mastopexies at the same time, and I think the scars heal very well. This is a patient who wanted the implants removed. 5 years ago, I started using the Chrysalix imager to document the amount of asymmetry to help me plan how much to take out from both sides. On occasion, it's also helpful to let a patient visualize how much of a reduction, what it will look like afterwards. I've done a total of 1,450 reductions in a 25-year period. The average volume removed was 800 cc's. Average reduction is 2 cup sizes. I compared this to a series that was published by an author who thought she had great results, and you can see my complication rate is significantly lower. Complications when people review it don't include numbness, which is common, inability to breastfeed, and dehiscence, or I guess it does include dehiscence, but that's very common. I see advantages with normal sensation. I think my shape is improved compared to many of the techniques out there. Ability to breastfeed does matter to patients. Potential to detect breast cancer, it's hard to prove, but I believe this is better. And because it's a very short procedure, patients also have multiple procedures at the same time. This is a before and after on a mammogram. There is no destruction. It is more dense. There are some patients who then have MRIs rather than mammograms if they're really dense. But I see that as an advantage because it's much better at picking up breast cancers. I have only had 3 cases of breast cancer that I know of, which is extremely low. There may be cases I don't know of, but all 3 were thrilled that they had the procedure because they said when their breasts were so large, they never would have noticed the breast mass. There also are articles showing that there could be lower breast cancer after reductions. So in conclusion, I believe there's a higher level of patient satisfaction, definitely less scarring, less pain, quicker recovery to work. How often do you send patients back to work in 1 week like I do? Normal activity is immediate, and compared to the cost of procedures that take hours, this is a big savings. Thank you for your attention.
Terrific talk. What questions does the audience have?
Thank you, sir. Thank you, sir. That was a great talk. Sunny Chatterjee, Tufts. A lot of my breast reductions are insurance based.
Yeah.
Does this type of technique